Welcome to this Case Med Minute video. We're going to be talking about arthritis. So this is the question for today. If you'd like to pause the video and try it on your own, go for it. Otherwise, let's get started. So the first sentence reads, a 62-year-old woman presents with chronic right knee pain that has gradually worsened over the past 2 years. So I guess this has been going on for 2 years. It's definitely chronic. It's gradually worsening, and this could be a whole bunch of things. I put a couple of thoughts at the top. Of course, osteoarthritis and rheumatoid arthritis are always my kind of top two thoughts whenever I see chronic joint pain. Lupus could be, leave that on the differential, something like psoriatic arthritis, something like pseudogout, and this is not an exhaustive list. Um, but let's keep reading. So she reports stiffness lasting about 15 minutes in the morning and increasing discomfort with prolonged walking. So this is getting at osteoarthritis. Why? Well, osteoarthritis will have a short amount of morning stiffness contrasted with an inflammatory arthritis like rheumatoid arthritis that will have a much longer period of stiffness in the morning, usually more than 30 minutes or an hour. Also, there's discomfort with prolonged walking. So with using the joint, there's more pain, which again fits with an osteoarthritis versus rheumatoid arthritis, where you'll often have decreased pain with movement. And here's the kind of classic picture. So osteoarthritis being a degenerative disease, as we said, morning stiffness lasting less than 30 minutes. You can have some other classic findings like Herbert's nodes, which are I'm putting a picture here, but these kind of um, swellings of the DIP joints. And then rheumatoid arthritis is an autoimmune disease. You'll have this prolonged morning stiffness, and it's caused by an inflammatory kind of process. Um, so next sentence reads, physical exam reveals bony enlargement of the knee, crepitus, and decreased range of motion. This doesn't really give us like too much information. Um, Kind of describes a lot of knee problems. But let's keep reading. So x-rays reveal a joint space narrowing, osteophyte formation, and subchondral sclerosis. So again, this is kind of fitting with our thought of osteoarthritis. So you'll have these osteophytes, which are kind of these outgrowths of bone along the joint. You'll also have subchondral sclerosis, which is this breakdown of the bone underneath the joint, versus again comparing with rheumatoid arthritis, where you'll have an erosion of the cartilage, and you can have other things like a pannus, kind of some inflammatory infiltrate around the joint. So, which of the following is the most likely diagnosis? We already think it's osteoarthritis, but let's go through the choices just to think a little bit more about other causes of arthritis. So, gout, it's probably not this, right? This is an acute inflammatory process of a single joint, classically the big toe. And this is caused by precipitation of urate crystals in the joint, which cause inflammation and pain acutely. And if you were to draw the synovial fluid during a gout flare, you would have these negatively birefringent crystals, which are shown in this picture right here. So probably not gout. And then just to think about another option, which isn't an answered choice, but calcium pyrophosphate disease, sometimes called pseudogout. This is seen in older patients, and it can have an acute inflammation, this kind of pseudogout flare, or it can have more chronic degeneration. So that might fit with our patient type of picture. However, one thing that we don't see with our patient, which is commonly seen here, is chondrocalcinosis, which is calcification of the cartilage on X-ray. So then what about psoriatic arthritis? Well, we don't have any skin findings for this patient. Not to say you couldn't have joint pain without skin findings in psoriatic arthritis. I was reading kind of 1 to 15%. So can more rarely happen, but probably not in a step one style question. And the other kind of finding that you see with psoriatic arthritis is you'll see this pencil and cup deformity at the DIP. So I put a picture, kind of just a clip art picture of what this looks like, and then you can see a very dramatic version of this pencil and cup on this x-ray. Other seronegative spondyloarthritis. So these are arthritis without a positive rheumatoid factor, but that are still kind of more inflammatory. Ankylosing spondylitis. This is classically in younger men, so not the same demographic as our patient. You'll see bamboo spine. You'll usually see spine and sacroiliac joint involvement, and then also findings like uveitis and then aortic regurg. And then inflammatory bowel disease. Again, our patient doesn't have IBD, but that can cause an arthritis. And then reactive arthritis, which is a classic triad of conjunctivitis, urethritis, and arthritis. And then lastly, septic arthritis. Again, this would present acutely. So this is not our patient's picture, and you would have this red swollen joint, um, most commonly caused by Staph aureus. So whenever you see septic arthritis, that's the pathogen that I would be thinking about. Um, like I said, affected joint is swollen, red, and painful. And then when you draw a sample of the synovial fluid, it's going to be purulent, having tons of white blood cells, usually over 50,000 is the kind of cutoff that they go for. And then you're going to treat with antibiotics, aspiration, drainage, with or without debridement. And just to give you this kind of classic table of the numbers to differentiate what type of inflammatory or non-inflammatory process is going on in the joint. Because you could think, our patient has chronic knee pain, but if you had someone coming with acute knee pain, it could be inflammatory, it could be arthritis, like osteoarthritis, it could be septic arthritis. So you might draw a sample to figure out what it is. So if it's non-inflammatory, so something like osteoarthritis, you're going to have a very low amount of white blood cells, maybe around like 200. Inflammatory is more in the like 10,000 range, so something like rheumatoid arthritis. And then septic arthritis, like I said, is this above 50,000. So I would keep that 50,000 number in your mind. And if you see a huge number of white blood cells, you're thinking septic arthritis. So just to kind of round out the discussion, talking about osteoarthritis versus rheumatoid arthritis. Osteoarthritis caused by mechanical wear and tear, damaging the joint, versus rheumatoid arthritis, which is an autoimmune process causing inflammation, which erodes the cartilage. Being kind of an older female is kind of the demographic for both of these potentially. But presentation would be pain with weight-bearing joints after use, like our patient has pain with walking that improves with rest, versus rheumatoid arthritis with this prolonged morning stiffness greater than 1 hour. Pain improves with use. Joint findings for osteoarthritis being osteophytes, subchondral sclerosis, versus rheumatoid arthritis, where you'll see cysts, you'll see joint space narrowing. And then treatment, you may start with NSAIDs for both osteoarthritis. You can consider intra-joint steroid injections for like a kind of worse prolonged presentation. And then for rheumatoid arthritis, you're often going to be thinking about disease modifying therapies, classically methotrexate. So our answer here is going to be B, osteoarthritis.